Hello, everyone. My name is Jim Douketis, and on behalf of tonight's panel, and also on behalf of Thrombosis Canada, I'd like to welcome you to tonight's webinar on COVID-19 management, insights, treatments, and challenges. Next slide. Now, you might be wondering why Thrombosis Canada is involved in COVID-related presentations. Well, our faculty, of which all our Thrombosis Canada members, save one, are in fact frontline internists, frontline family physicians, and frontline emergency physicians who have been involved in the care of patients with COVID-19 over the past 2 years. So we hope to share with you some of our insights into some of the recent developments. Next slide. These are my disclosures for tonight's presentation. I'd also like to disclose that we have received an unrestricted educational grant from Pfizer Hospital for this presentation. Next slide. As always, we place a great emphasis on mitigating potential bias through our independence of this presentation, and we look to your input as regard to this at the end when we do an exit survey. Next slide. This presentation is also accredited, and we hope you take advantage of this accreditation offer. Next slide. So really the learning objectives of this evening are very germane. So we want to discuss new developments and guidance on the management of patients with COVID-19. And I'm pleased that we have really a multidisciplinary panel this evening that includes myself as a general internist, Dr. Lana Castellucci, a hematologist and general internist, Dr. Alan Bell, a family physician, and Dr. Benjamin Bell, a general internist. And we're delighted to also welcome Dr. Dominic Mertz, a infectious disease specialist. So we're going to probably try to provide you with a very holistic, multidisciplinary view of some of the recent developments to achieve these learning objectives. And although we're going to go through the entire journey of the patient with COVID-19 from the outpatient setting to the emergency room to the in-hospital setting and post-hospitalization, we will focus though on the outpatient setting because that's where a lot of the new developments in the care of patients with this condition are located. So next slide. So here is our agenda. As I said, we're going to span that kind of journey, starting with the newly diagnosed COVID-19 patient who's presenting to a primary care setting and who does not require an ER visit. So I'm going to hand it off now to Dr. Alan Bell.
All right, thank you very much, Jim. These are my disclosures. As Jim mentioned, I'm a family physician. And we'll be presenting this evening the family physician perspective on the management of the COVID patient. So in doing so, let's take a look at Charlie. Charlie is a patient of mine who I assessed by telephone consultation. He's a 67-year-old auto mechanic complaining of fever, productive cough, headache, and myalgia of 3 days duration. Importantly, he was not complaining of shortness of breath, chest pain, or any GI symptoms. He's living with his wife and his adult daughter, and the whole family is fully vaccinated. And by that, I mean 2 shots, in their case, of an mRNA vaccine. He is COVID-19 positive, 1 day positive prior to his presentation, demonstrated on a PCR test. He has some significant comorbidity with hypertension, hyperlipidemia, obesity, and he's got a 20-pack year smoking history under his belt, not officially diagnosed with COP, but certainly with that history has very high risk for it. His current medications include an ACE diuretic combination and a statin. Next slide, please. So what are the considerations that we have to have when Charlie walks into the office? Well, from a public health perspective, the first thing that we have to really think about, importantly, is the isolation strategy. This is what the patients want to know about, and this is probably one of our most important roles as primary care physicians to ensure that this strategy is being followed. We have to consider the patient himself. We have to consider the household contacts. We have to also consider casual asymptomatic contacts. Other considerations are what further investigations he may require, how he should monitor it, when we should or if we should refer this individual to hospital and what follow-up care is required. What treatment options do we have available? Well, we've got to consider the anti-inflammatory drugs, including inhaled and perhaps oral steroids, fluvoxamine, colchicine, tocilizumab are all anti-inflammatory drugs that have demonstrated benefit in COVID, but not necessarily in the outpatient settings that we're discussing. There's also antiviral therapies to consider, certainly Remdesivir, and the new kid on the block, Nirmatrelvir, Retonavir combination being marketed as Paxlovid, and hopefully soon to come Molnupiravir, which is going to be sold under the trade name of Lagevrio, but we really haven't heard any news on when that might find its way to the market. We also have to consider the utilization of SARS-CoV neutralizing antibodies, and the effective one now against the Omicron variant is sotrovimab. None of the other monoclonals have shown benefit against it. And then to be discussed later in the program is issues around anticoagulation, particularly for the hospitalized patient. Next slide, please. So let's get right into it. Let's talk about the isolation strategy. And this is data that I have extracted from Toronto Public Health. It is specifically aimed at patients in this jurisdiction. The jurisdiction that you're in may have very different recommendations, but what we're doing here is for the patient, it is going to depend on whether he is vaccinated and whether he is immunocompromised. So for the fully vaccinated, non-immunocompromised patient, or children under the age of 12, the recommendation is self-isolation for 5 days from symptom onset or positive test, whichever came first. And importantly, until he is demonstrating improvement, not necessarily resolution, but improvement in symptoms for at least 24 hours if they're respiratory or 48 hours if they're gastrointestinal. It's different for the non-fully vaccinated individual or those who are also over the age of 12, or those individuals who may be vaccinated but immunocompromised and will shed virus longer. So those individuals are asked to self-isolate for 10 days from symptom onset or positive test, whichever came first. Additionally, they also have to show improvement in their symptoms for 24 or 48 hours in the case of GI symptoms. The new recommendation that has also come by that is not on this slide is that patients who are severely immunocompromised, in the judgment mostly of the treating physician, they are asked to self-isolate, in fact, for 20 days, regardless of immunization status. Household contacts, it's very simple. Household contacts are asked to self-isolate for the same duration as the case itself. When the patient can remove from self-isolation, so can household contacts, unless they have become symptomatic during the course, in which case they are also asked to self-isolate for 5 days from symptom onset. And what about asymptomatic contacts? Well, first of all, what are asymptomatic contacts? Asymptomatic contacts are those individuals who the contact has been in contact with within 6 feet for at least 15 minutes without wearing a mask. So that really cuts it down. And patients will often ask that, geez, you know, I was in a big crowd of people. Anyways, in these individuals, testing certainly is not recommended. They are asked to self-monitor for symptoms for 10 days and not to visit high-risk settings or high-risk individuals. So this comes to bear for healthcare practitioners who are asked not to attend places like hospitals for a more prolonged period. Certainly not to come in contact also with grandma and not to be going to long-term care facilities. And they are only asked to self-isolate if they are immunocompromised or unvaccinated, in which case these individuals are asked to self-isolate for 10 days from their last contact or 5 days if they're kids under the age of 12. Next slide, please. Now, what about treatment? Okay, so treatment has become exciting. We've got a new antiviral out there. We've got the monoclonal antibodies. We've got fluvoxamine. We've got inhaled steroids. So who are these drugs for? Well, the Ontario Science Table has stratified individuals for risk of developing severe illness based on their age, their vaccine status, and whether or not they are immunocompromised. The highest risk individuals, the tier 1 individuals, are those individuals who are either immunocompromised, and immunocompromised, taking compromising drugs, have diseases that are associated with loss of immune function, or individuals who are unvaccinated and at highest risk, and those are individuals over the age of 70 or 60 if they are indigenous or have comorbid conditions. And the comorbid conditions are listed below, include obesity, advanced renal disease, diabetes, and the others that you see listed below. And when using the treatments for the tier 1 individuals, the older individuals should be prioritized where there is a lack of the appropriate agent. Tier 2 are, again, the unvaccinated individuals who are over the age of 60 or 50, so 10 years younger to move you down into the lower strata of tier 2. Now we move over to the vaccinated individuals who are into compromised tier 3 and 4. And as you see, they mirror what we are seeing with the unvaccinated with regard to age. So 70 or 60 with comorbidity. And again, we want to prioritize the higher risk individuals as well as those who are greater than 6 months out from their last vaccination, and tier 4 are just 10 years younger. Next slide, please. Before I advance, I should also say that with regard to pregnant patients, which is a question that often comes up in primary care, it has to be really an individual case-by-case decision, recognizing that pregnancy does indeed increase the risk of developing severe illness. At the same time, though, these individuals tend to be younger and healthier, and therefore mitigating their risk associated with the pregnancy. But it is certainly something to be considered. And also we have to consider the contraindication of treatment in some of these pregnant patients with some of these drugs. Next slide. So here it is. Here's the current treatment. And this is the third time we've given this presentation. And this is the third time I've had to change this slide based on the recommendations of the science table. So sotrovimab is recommended as the first line therapy for patients at the highest risk, those being tier 1 and tier 2, and we do not differentiate between them except to prioritize the tier 1s over the tier 2s when there is a lack of medication. So 500 milligrams intravenous single dose if the patient presents within 7 days of symptom onset. And this is regardless if they're immunocompromised of their vaccine status. This is to be done as an outpatient, and it should obviously be reserved for patients who have a reasonable expectation of surviving at least a year or so. Now, how do I get intravenous sotrovimab as a family doctor? Well, it's not easy, but the answer that I usually provide is that most hospitals have a rapid COVID assessment clinic that, if you contact, will tell you the nearest facility for which there is an infusion of sotrovimab available for your patients, and they really do try to get the patients in as quickly as possible. If sotrovimab is not available in these unvaccinated or immunocompromised patients, the next choice is nirmatrelvir Retonavir combination, being marketed as Paxlovid. It's given as 2 separate pills, 300 milligrams of nirmatrelvir, 100 milligrams of Retonavir, which is taken twice a day for 5 days if the patient presents within 5 days of symptom onset. It should be noted, however, that in patients with renal compromise, the dose is reduced to half of what we would otherwise give of the nirmatrelvir component, and if patients have an EGFR under 30, then the drug is contraindicated. It's important to know that the Retonavir portion of the drug is put there not as an antiviral, but as a drug to inhibit metabolism of the nirmatrelvir. And it should be aware that it is also going to inhibit the metabolism of other drugs because of its action of inhibiting cytochrome CYP3A4. So be aware that there are going to be drug interactions, and many drugs with narrow therapeutic ranges, such as direct-acting oral anticoagulants, have to be considered very carefully when you're prescribing this drug. And this drug also is not recommended in pregnancy. Now, if neither of those are available, you may consider fluvoxamine, 50 milligrams 3 times daily. To start, bumped up to 100 milligrams 3 times daily to be taken for 15 days. I will point out that this is generally considered to be the maximum dose of fluvoxamine when it's used for psychiatric indications, and it may be associated with some significant side effects. And I would also point it out that it's in yellow as a considered treatment because of the really low certainty of the evidence that we have supporting it. The same is true for budesonide, inhaled budesonide, 800 micrograms inhaled twice daily for 14 days. Also based on low certainty of evidence. And, you know, this is also a drug that you may want to consider in patients who may benefit from it anyways, like our patient, the long smoking history, perhaps a patient with COPD. And finally, Remdesivir, which was recommended in these patients at the outset, is no longer recommended because of the limited availability and the drugs to be prioritized for patients who can perhaps see more benefit from it. Next slide, please. Now, when we move down to tier 3 and tier 4, our vaccinated population, you will notice that sotrovimab, remdesivir, nirmatrelvir, retinavir are no longer recommended in these patients, and that is based on the limited supply that is available, and it's to be reserved for higher risk patients. However, the fluvoxamine and budesonide treatment options certainly may be considered in these patients. Next slide, please. Patients who don't fit into tier 1 through tier 4, they get gentle reassurance, they get self-monitoring, which optimally would include the use of a pulse oximeter if that's available to you, but no drugs are recommended for these patients. Next slide, please. Drugs that are specifically recommended against, you see on the right side, which include antibiotics such as azithromycin, which is getting sloshed around quite a bit, monoclonal antibodies that are not effective against the current strain, hydroxychloroquine or chloroquine, ivermectin, and lopinavir, retinavir are specifically not recommended because they offer no benefit, and all of these drugs offer some risk of harm. Currently not recommended, but may have some promise include colchicine, interferon, as well as vitamin D. Next slide, please. Monitoring and follow-up, I think the most important thing, as I mentioned earlier, is to get these patients to remain self-isolated, and while they are, to make them aware of red flag symptoms. Most importantly, worsening shortness of breath. I like to use the expression trouble breathing to my patients who may not understand what we very quickly recognize as shortness of breath. Importantly, something that is often not mentioned is the GI side effects of this, of this virus. Persistent vomiting and diarrhea can lead to dehydration. If it's associated with increased inability to take fluids, episodes of syncope or pre-syncope, or reduced urine output, these are red flags for which the patient should seek medical care. Providing a home pulse oximeter is a great thing if you can do it. I was fortunate enough to apply in time to a program in Ontario called COVID at Home, and I got a supply of these things, and I hand them out to my higher risk patients. If you can do it, it's great. And I usually tell them if they drop below 92, that's time to be concerned, assuming that that's a drop from their baseline. Routine follow-up, I usually touch base with them in a week. Next slide, please. So I'm going to go very, very quickly over the principal study, which examined the value of budesonide in treatment of patients with COVID who do not require admission. It was a well-conducted, multi-center, multi-arm randomized control trial, but I will point out that it was open-labeled. Patients were eligible if they were 65 or older, or 50 with comorbidities, and they could enroll in the trial if they had illness for up to 14 days, but they were not required, in fact, to have a COVID positive test. But a subgroup looking at the COVID positive patients was also conducted. Next slide, please. 4,700 participants, over 1,000 of which received 800 milligrams of budesonide twice a day for 14 days. Another 2,000 who were given just usual care, and some other treatments were also looked at in 1,500 patients. Next slide, please. And the result was they were looking at the endpoints of time to reported full recovery. And in fact, budesonide shortened that by about 3 days. And that was a statistically significant outcome. With regard to the other outcome of this trial, which was hospitalization or death at 28 days, there was a 2% absolute increase reduction in hospitalization, which gave the number needed to treat of 50. Not a bad outcome in this population. But I will point out that it missed hitting the statistical significant margin where the point estimate did cross 1 at 1.03. However, the authors did a secondary analysis where they did what was referred to as a probability of superiority, and it was felt to be over 96% probable that it was superior over usual care. Next slide, please. So how did I manage Charlie? Well, I educated him regarding the red flag symptoms that we went over. I advised him and his family to self-isolate for 5 days with home precautions. I did, in fact, provide him with a home pulse oximeter, and I gave him budesonide 800 micrograms twice a day for 14 days, and his outcome was just fine. Thank you very much. And next slide, please. So for a deeper dive into some of this, I will turn it over to my colleague, Dr. Dominic Mertz. Dominic?
Thank you, Alan. Yeah, I will go into a little bit more depth to make it maybe easier for you to understand as to why the current recommendations are what they are. And I will talk a little bit more about the monoclonal antibody, so Sotrovimab. Again, touch on Remdesivir, provide you with the data there. Then spend some time on Mertz, Retonavir. I will just use the term Paxlovid because it's easier. I will touch on Fluoxamine as well, and will not talk about budesonide again because you already heard what the data shows. So all the treatments for tier 1 and 2, and a couple of which, as you're aware, are also opted for tier 3 and 4. Next slide. So the first, the monoclonal antibodies, and as Alan said, the one that is active and available in Canada against Omicron is Sotrovimab. Showing you one of the studies here. In general, we see for monoclonal antibodies what we see here in terms of preventing hospitalization. Typically, it's a composite outcome for hospitalization or death. All those studies that I'm showing you have been done in unvaccinated, non-immune individuals, and we sort of generalize from that data to vaccinated but heavily immunocompromised individuals, because our assumption at this point is that their immune response is probably similar or negatively affected to the extent that you can treat them or have to treat them as unvaccinated. What you see here for Sotrovimab is a adjusted relative risk ratio of 0.21, so roughly an 80% reduction in the risk of requiring hospital admission for more than 24 hours or death due to any cause. When we go to the next slide here, you see the other intravenous option, Remdesivir. And as Alan already mentioned, while we would have told you a few weeks ago, Remdesivir would be the other option that you have for those mildly symptomatic but high-risk individuals for developing more severe infection down the road. We would be using Remdesivir. We are telling you now, no, it's at best in the reserve in case nothing else works, but you really want to use the Remdesivir currently for the moderately ill, about which we will be talking later. But it's not because we believe it doesn't work. The data that you see here is the Pine Tree RCT, relatively recently published. I believe it was back in December, around Christmas time. And what you can see here is an effect similar to what I've shown you for Sotrovimab. So again, outcome being a composite of COVID-19 related hospitalization or death, and the hazard ratio of 0.13. So the hazard has been reduced by 83%. So again, similar ballpark as sotrovimab. They also looked at the day 14 as a secondary outcome, and interestingly, you see nothing happened between day 14 and day 28, the exact same event rate here. They also looked at COVID-19 related medically attended visit or death as a secondary outcome. Similar effect size there in the range of 0.8 to 0.9 reduction. So overall, very promising data. But given that we have limited supply for Remdesivir and convincing data for the moderately ill as well to prevent even more severe outcomes, ICU admission and death, the current recommendation is to sort of use the limited supply of Remdesivir for the sicker population and the mildly symptomatic in the community, also because we have other options. I introduce you to monoclonal antibodies, and we go to the next then. But just in summary, that's the next slide here. So sotrovimab and Remdesivir, both are IV infusions, so you require access to an outpatient clinic with the appropriate setup. You need a referral process, and you also need to make sure, and that's true for the other drugs that I will introduce as well, that patients know that they should get tested, that they have a relatively quick access to their PCR testing optimally, and that then a referral process is in place to get those patients to the outpatient clinic relatively quickly. The time window for both sotrovimab and Remdesivir is up to 7 days from onset of symptoms. As you've already heard, for Paxlovid, it's only 5 days. So time becomes potentially challenging, in particular, given that people typically are concerned on the first day of their symptoms. So there's first a delay until you get tested, then until you have the test result back, and then you should still be within that time window long you have the result back and you're referred to a clinic. As I mentioned, the data supports benefit in the non-immune population, and we generalize that to other high risk and partially or fully immunocompromised individuals. Supply concerns, as mentioned, it sort of shifts around, but we don't have great, but currently better supply for sotrovimab than Remdesivir. That may look different again in a few weeks, but right now Remdesivir is really where we have the supply issues first and foremost. Next slide. Another option where we don't have supply issues at this point is the off-label use of Fluoxamine or Luvox, which is a selective serotonin reuptake inhibitor, so the SSRI, which has an immunomodulatory effect, which may be true across the entire class of these drugs, but the best data we have is for Fluoxamine. The first study here was done or published actually quite a while ago, November 2020. It didn't get that much traction other than, and that will be my next slide, as a large trial that followed that first trial, which almost looked too good to be true. But when you look at this trial, which was much larger, you were looking at more than 700 patients in each group. Again, a small minority only vaccinated, and first and foremost, the non-immune population in this trial. They used 100 milligrams BID for 10 days, started within 7 days of symptoms here. And you can see a relative risk reduction here of about 30%, a little bit more than 30% here. So not as effective as what I've shown you with sotrovimab and Remdesivir, and the outcome here is being hospitalization or need for an emergency care. So a slightly different composite outcome here, but a statistically significant improvement in terms of outcomes with Fluoxamine versus placebo. Next slide. More recently, I think published just in January, was this meta-analysis, again, mostly driven by the Together trial, which is the trial I just showed you. The the very early small one was Stop COVID, which had that risk reduction in the range of 80%, which looked like a little bit too good to be true. Then was Stop COVID 2, which didn't show a significant effect. The effect in the meta-analysis here was really driven by the Together trial, given its size and the larger number of events. So at this point, we assume roughly 25% risk reduction. Next slide. The caveats with fluvoxamine are interactions, including the risk for serotonin syndrome with MAO inhibitors. The recommendation, and Alan already touched on that, is to consider to start with a lower dose. So the science table recommends a single dose of 50 milligrams on day 1, and then based on how well it's tolerated, either 50 or 100 milligrams BID the following day with a target of 100 milligrams BID with a duration of 10 to 15 days. Next slide. Then to the new antivirals, and molnupiravir or Lagevrio is the one not yet approved in Canada, and as Alan already mentioned, we haven't heard any news in terms of the timelines. This study has been published in the New England Journal of Medicine, as you can see here, around Christmas as well. This so-called Move Out trial had those very interesting findings where at the interim analysis, there was a 50% relative risk reduction in the outcome, which again is hospitalization for any cause of death. So that usual composite that you see in those trials. But then in the final analysis with the entire patient or participant population, the relative risk reduction was only 30%. And in particular interesting was that the event rate in the placebo group dropped from 14.1 to 9.7%. And it still remains a question mark as to why that's the case. Maybe they had a slightly different patient population in the first half of the patients that they would have recruited. Nevertheless, bottom line here is we are looking at a roughly 30% relative risk reduction of hospitalization, and clearly within the boundaries of statistical significance. Next slide. For Paxlovid, the data looks much better. The downside is we still haven't seen a peer-reviewed article on this data. So we have to rely on what's Pfizer been reporting through the media, which is basically 2 trials. There's the EPIC-HR trial. So HR stands for high risk, which are our non-immune high-risk population using similar criteria as the science table does with their tier 1, which showed an 88% relative risk reduction in hospital admission if treated within 5 days of symptoms in this high-risk patient population. They have a second study, which I believe enrollment has stopped at this point, but we haven't seen the final results yet, which is the EPIC standard risk trial, so EPIC-SR, which also showed a 70% relative risk reduction at the interim analysis, but didn't meet the criteria for early stopping the trial. So we are still waiting here for the final results. It also showed a 10-fold decrease in viral load, which may potentially have some impact on the risk of transmission, in particular within a household if you are treating someone with Paxlovid, and you may have better chances that people living in the same household may not get infected, but keep in mind that most transmissions occur in the first few days, by which Paxlovid will probably not have been started yet. Next slide. Main issue with Paxlovid is the Retonavir component, and again, you've already heard about it. The only reason why this is in the drug is to increase the half-life of the nirmatrelvir component, but this Retonavir, as you may know from HIV treatments, have major impact on many other drugs that we are using on a regular basis, and many of those high-risk patients may have one or the other. This is copied from the Sanford Guide. The Ontario Science Table has a great summary of the most important drug-drug interactions as well. Bottom line is, whenever you think about using Paxlovid, go through all the drugs people are on to make sure that there's no concerning drug-drug interactions, or you may need to adjust some of those other drugs the patients are on. Next slide. So in summary, the new antivirals, Paxlovid has been approved in Canada 3 weeks ago on January 17th. As I said, no timelines that we are aware of for Molnupiravir at this point of time. Canada reported that we have ordered 1 million courses of the Paxlovid and 500,000 courses of Molnupiravir. The time window to use is up to 5 days from onset of symptoms. It seems like the earlier the better, most likely based on what we know with other antiviral treatments such as Tamiflu, but the data seems quite convincing that up to 5 days patients benefit very significantly from the treatment. Regimen is BID as it's been already mentioned, and it's a 5-day course. Next slide. I think Alan already touched on that. Unproven or harmful treatments, outpatient setting with mild disease. We have some data on colchicine, which looks promising, but it's not recommended at this point. Same applies to interferon, dexamethasone, tocilizumab. We will talk more about later on, which are really indicated for moderate and severe disease, not for mild disease. And then a list of unproven drugs that are occasionally used for one reason or the other, such as ivermectin, hydroxychloroquine, lopinavir, Retonavir, so Caletra, which is an HIV drug, azithromycin, vitamin C, D, and zinc, not recommended or recommended against. I would have to say at this point, not considered treatment for COVID-19, while they are appropriate drugs for other indications. That was my last slide. So let's talk about what to do with a patient who has to attend TED, and handing over to Dr. Jim Douketis.
Thank you very much, Dominic. So we're shifting the clinical setting now to the ER setting, and we'll go to our next slide and talk about Mr. D, who is a 67-year-old male, unvaccinated. We're dealing with the Omicron variant. He has a history of hypertension on medications, normal BMI, so relatively healthy for his age. Attended a small gathering a few days ago and now presents to the ER with a constellation of symptoms that includes sore throat and shortness of breath on exertion. You can see by some of the physical examination parameters that he's mildly ill, so he does fall into that mild ill category, not requiring oxygen, but in tier 2 because he's 60 to 70 years old and is not vaccinated. So I think one of the challenges, of course, as in any clinical area, is to try to determine what is going to be the clinical trajectory of this patient. And then competing with that is the need to try to keep patients out of hospital so that we're not overwhelming our already stretched healthcare system. Next slide, please. So in addition to our clinical gestalt, there have been attempts made to provide more quantified risk stratification tools to help us determine, what that clinical trajectory will be. And this is one example of such an effort, which looked at a number of determinants that would, in this case, predict for adverse clinical outcomes. This is COVID-related death. And you can see that the 4 major independent predictors involve the parameters of oxygenation, or O2 sat, the body mass index, or the presence of obesity, age, of course, and respiratory rate. Now, a lot of these, of course, are part of our own clinical judgment or gestalt, but I think these kind of tools are helpful especially, if we're in a situation where we don't have a large volume of these type of patients, and these clinical guides provide us with a bit of a background, if you will, to make a judgment and as to the clinical trajectory, and importantly, whether that patient can be safely treated at home. Next slide, please. So we heard from Dr. Bell and Dr. Mertz about what we have within our therapeutic armamentarium, if you will, to try to keep patients out of hospital, to have them treated at home, and what's in that outpatient treatments shelf. And a lot of the treatments that were described are pertinent also for the ER setting, and whether it's sotrovimab, fluvoxamine, budesonide, and others. This is something that we want to consider in this setting, because the objective is to keep patients off oxygen and out of the hospital. And part of that, in terms of other supportive care measures in the outpatient setting, of course, depending on the individual's background and their other healthcare needs, ensuring, simple things like rest and hydration, but also providing with quantitative measures like oximetry to determine, is that person deteriorating, and to try to capture them and try to have them come into a better, more appropriate healthcare setting if there is that type potential for deterioration. And of course, having measures in place for follow-up. And now we have the advantage of being able to do this virtually, in addition to more traditional kind of follow-up measures. Next slide, please. So one of the things that I'd like to make you aware of, and of course that this evidence is emerging, is that there are a number of excellent resources available to us healthcare professionals in Canada that they can access to look at what the latest evidence is on treatments. In Ontario, we know about the Ontario Science Table, and there are similar organizations in other provinces. This is looking at sotrovimab from a website that was developed at McMaster University in collaboration with Canadian Institutes of Health Research. And I simply mention this for you to provide you with a resource. And what this group does is that it takes various guidelines and recommendations from all over the world. This one here from the United States, looking at sotrovimab. Next slide, please. And this one here from an Australian guideline looking at budesonide, providing a very concise summary about these agents and where they fit into that therapeutic shelf, if you will, and the evidence in support of these agents. And of course, similarly, to provide us with information about agents that you heard about that we do not recommend, and that are out there in various forms and various media. Next slide, please. And this is just one other example from the BC COVID Therapeutic Committee that provides a really deep dive, if you will, into a number of these treatments, once again, sotrovimab or budesonide, and looking at the evidence. So there's a lot of great resources out there that can help you in terms of decision-making alongside our clinical judgment and the aforementioned decision tools that I alluded to. Next slide, please. And the same here, further deep dive into the treatments. Next slide. So unfortunately, this patient deteriorates clinically as he comes back to the emergency room. He's feeling worse, more short of breath on minimal exertion. And now his oxygen saturation is in the 80s. So clearly, this is a type of patient that you would see in the ER setting. If I'm an internist asking to consult on them, it would be pretty clear to me that this patient needs hospitalization, and the number of treatment options that we have for in the hospital setting to try to avert, if you will, further deterioration, intubation, and so on. So with that, we're going to shift now from we've gone from the outpatient to the ER, and now we're going into the inpatient clinical setting. And I'm going to introduce our next speaker, Dr. Benjamin Bell, an internist, to talk about pharmacologic standards of care for COVID-19 patients who are hospitalized. Over to you, Ben.
Thanks very much, Jim. Next slide, please, Holly. These are my disclosures. Next slide, please. So, the paradigm for treating patients with COVID-19, I think, shifts when individuals are hospitalized, at least to an extent. As an outpatient, we're primarily focused on antivirals and utilizing therapies that target the virus. And while that remains true for hospitalized patients as well, the shift more so moves towards addressing the secondary effects of the virus on the body, namely immune modulation. Next slide, please. So there are several standards of care that we use for individuals who are hospitalized with COVID-19, and the first focuses on immune suppression, are steroids, and in particular, it's dexamethasone that's used. We've known for a long time that dexamethasone is helpful in individuals with COVID-19, and this is one of the seminal trials on the matter. This trial randomized patients to either receive dexamethasone or essentially standard of care at the time, which was nothing else. And they looked at all tiers of patients with COVID-19, those in the ICU, on mechanical ventilation, those receiving oxygen therapy, and those individuals who weren't receiving oxygen at all. And what was found is that in all comers, those who received dexamethasone were less likely to die, with a relative risk of 0.83. But I think there are some important subgroups here that need to be looked at. And what you can see is that the sicker you were with COVID-19, the more benefit you gleaned from systemic therapy with dexamethasone. And in fact, in individuals who weren't receiving oxygen, there's evidence of harm with dexamethasone. And so really, we are reserving systemic steroids, dexamethasone therapy, for individuals who are in the hospital and receiving oxygen therapy. That's really in the basis of this trial. Next slide, please. And so what we've seen is there's a mortality benefit for those in the ICU, and there's also a suggestion that you're liberated from the ventilator faster if you receive dexamethasone. There's a mortality benefit for the ward patients, as you saw on the last slide as well. And in addition, there's suggestion that there's less escalation of care to requiring a ventilator if you receive dexamethasone. As highlighted already, there's no benefit if you're receiving oxygen. In the overall trial, all comers, including those not in oxygen, the number needed to treat is only 35 to prevent one death, and that number goes up if you're sicker. The dose is 6 milligrams daily for 10 days, and that's either given orally or IV, and the stuff is dirt cheap. Next slide, please. There's been a lot of talk about Remdesivir. You've already seen the data that was published in the New England Journal in December of 21 regarding individuals right at the onset of their illness, and that was pretty powerful data. Prior to that, we've known that Remdesivir does work as well for individuals who are in hospital and on oxygen. Interestingly, though, as I've discussed already, the focus of patients who are hospitalized is more so on the anti-inflammatory aspect of things rather than on the antiviral side of things. And so, unlike with dexamethasone, where the sicker you are, the more important dexamethasone is and the greater its effect is, the opposite is true of Remdesivir. So the sicker you are, the less benefit there is to be seen with Remdesivir. And that's probably because when you're in the hospital, when you're on more oxygen, it's more of the inflammatory phase of the illness rather than the viral replication phase of the illness. And so this was published earlier in 2021, and it was an early meta-analysis on dexamethasone, which is primarily which is primarily influenced from the results of the ACT-1 and the Solidarity trial. There are a bunch of other smaller trials in here, but as you can see, they have very wide confidence intervals. And I want to draw your attention to the highlighted part of this slide. So in individuals who are at lower risk, in particular, those who are not ventilated, the evidence shows that the risk of death, the relative risk of death is 0.8 compared to standard of care. And so, this did cross the line of unity with the upper confidence interval being at 1.01. However, in combination with the other data we have for remdesivir and what has been observed is that this drug this drug is quite effective for those who are in hospital, who can take IV therapy, and assuming they're on low flow oxygen. When individuals are higher risk, in particular, meaning receiving high flow oxygen or on the mechanical ventilator, the benefit of remdesivir is lost, and it's essentially at 1. There's really no evidence that remdesivir is helpful when you are sicker. Next slide, please. So how does remdesivir work? Well, it's a nucleoside analog, and so in doing so, it inhibits viral replication. The reverse transcriptase and the virus can't get past the that analog, and so viral RNA replication is stopped. As mentioned, there's no benefit in those who are critically unwell. Those individuals, it appears, are past the viral replication stage of the illness and more into the inflammatory stage of the illness. There's no benefit regarding mortality or intubation, although the mortality benefit is very close to achieving statistical significance, and probably would have achieved it if the trial was a bit larger. There may be a reduction in time to recovery, but there's not a major change in the length of stay of individuals who receive remdesivir. There's really no significant toxicity to the drug, and you need to treat about 143 patients to prevent one death. Big difficulty with the drug is it's given by intravenous therapy only, and so it's 200 milligrams once and then 100 milligrams daily for 4 days. And in fact, in the context of drug shortages that are occurring right now, our hospital has reduced that to 100 milligrams for 3 days following that, and it costs about $3,100 for a 5-day course. So I'm just going to briefly mention the newer antivirals here. Those antivirals are predominantly being used in individuals who are not on oxygen and who can take oral therapy, of course. I'm not bringing it up in more detail here because they're primarily outpatient medications. Although there are a select group of patients who are in hospital with COVID-19 who are at high risk, who may benefit from those drugs, and so we do use them in the hospital rarely. For example, for nosocomial cases. Next slide, please. A very potent drug to help inhibit the immune system is tocilizumab. Tocilizumab is given by IV therapy only. This is one of the larger trials that looked at the drug, about 4,000 individuals in the trial. And what was observed in the highlight is that the risk of death if you receive tocilizumab versus standard of care was again 0.86, and that did achieve statistical significance. The individuals in this trial were almost entirely high risk, as in, were almost entirely critically unwell, so mechanically ventilated or receiving high flow oxygen, and they all had very high inflammatory markers. Specifically, their CRP was more than 75. So again, this drug is really targeting individuals who are well outside of the viral phase of the illness and into the inflammatory phase. Next slide, please. And so tocilizumab is given to 25 people and prevents one person from dying. It's associated with reduction in death and the need for mechanical ventilation if you're not already ventilated when you have it. The dose test in the trial was 8 mg per kg times 1, but what's being given in the context of shortages that exist right now is a 400 milligram single dose, and that costs around $1,000. Next slide, please. In the context of tocilizumab shortages, there are other drugs that we can use. In particular, there's Paracetam, which is a JAK1 and 2 inhibitor. This is a meta-analysis that was done by the Ontario Science Table, in fact, late last year, looking at the 3 large trials that investigated Paracetam. They had similar inclusion criteria to the tocilizumab trial, being patients who are quite unwell with elevated inflammatory markers. And again, what was seen with Paracetam is is a reduction in death if the drug was given. Next slide, please. And what we're seeing with Paracetam is, again, 33 patients treated to prevent one death. It's an oral drug. It's 4 milligrams daily for a total of 14 days or until the patient is discharged home, and it costs around $1,400. We should be using tocilizumab or baricitinib, not both agents. There's no data testing both agents. Locally, we use tocilizumab as a default, and if it's not available, then we move to baricitinib, although the data for the two appear quite similar. Next slide, please. Couldn't talk about COVID-19, especially in a talk given by Thrombosis Canada, without at least bringing up venous thrombosis and anticoagulation. We know COVID-19 is a hypercoagulable state, with the rate of VTE in outpatients being 1 in 100. Although that may be an overestimation, it's really hard. It's really hard to estimate because we don't know the size, of the denominator. In ward inpatients, the rate of VTE is around 5% or less, and in ICU patients, it's between 5 and 10%. Next slide, please. And so obviously those rates are higher than what we would observe for similar respiratory illnesses like influenza or pneumonia. And so that's raised the question, should we be increasing the intensity of anticoagulation for individuals who have COVID-19? And there's a lot of data out there, or there are a lot of trials that have been done asking that question. I'm going to focus on the hospitalized portion, and I'm only going to focus on a couple of trials in this space as well. Next slide, please. The good thing really is that I think the data is, at least in the best conducted studies with the largest numbers, really suggest a somewhat uniform finding, which is that therapeutic anticoagulation, when compared to prophylactic anticoagulation, is superior for individuals who are admitted to hospital and on oxygen, assuming they're not critically unwell, as in they are not on a ventilator and they're not on high flow oxygen. So if you're admitted to hospital and you're on the medical ward receiving oxygen by nasal prongs, and assuming you're not at a high bleeding risk, we're going to be giving you therapeutic doses of low molecular weight heparin for prophylactic indications. If you get sicker, or if you're in the ICU, so as in if you're ventilated or if you move to high flow oxygen, the dose of the anticoagulant is going to be reduced, typically to an intermediate dose of low molecular weight heparin. So a little bit more than prophylactic dose, but not quite a therapeutic dose. Next slide, please. And with that, I'm going to pass the torch on to Dr. Castellucci, who's going to talk about the standard of care following hospitalization.
Great, thanks very much, Ben. Next slide, please. And these are my disclosures. We'll just leave those up for a moment. And then next slide, please. So I'm going to continue on with this patient that we heard about before. So this was the patient that initially presented to the emergency department, was discharged because he wasn't unwell enough at that initial presentation to require hospital admission. But unfortunately, he did not improve while at home and was subsequently admitted to hospital, where he received some of the therapies that Ben has just reviewed with us. And now he's ready for discharge home. And while you're preparing his discharge orders and going through the EMR, you're wondering about some of the therapies that he received for his COVID treatment and what to do with them. Next slide, please. So we'll talk about each of these in turn, and we'll start with dexamethasone. Next slide. So because the patient was hypoxic during hospital admission, he was started on dexamethasone. And as Ben mentioned, this is 6 milligrams daily for up to 10 days. Next, please. What happens at the time of discharge really depends on whether or not the patient requires ongoing supplemental oxygen. So if the patient is going home without oxygen, then dexamethasone is stopped at the time of hospital discharge. But because of bed crunches, et cetera, during various periods of the COVID waves, we have had to send some patients home who are otherwise well but remain hypoxic on home oxygen. Next, please, Holly. And so if patients do go home on oxygen, What can happen is one of two things. You can continue dexamethasone to complete a 10-day course, but personally, I do not do that. So if a patient is, yeah, Holly, you can show that next part, please. So if a patient is requiring supplemental oxygen, I personally don't continue their dexamethasone to complete the 10-day course because they are otherwise better. And so I generally stop it. The caveat to that would be some patients develop cryptogenic organizing pneumonia as a result of the inflammatory response from COVID pneumonia. And in those particular patients, they're often started on prednisone at a higher dose of 1 milligram per kilogram, for example. And those would be patients where you would continue steroids post-discharge. And that's usually done in conjunction with a respirologist. And there's a taper that's scheduled for those patients. And so that would be the one caveat to continuing steroids post-discharge. Next slide, please. And then, as Ben mentioned, patients are receiving Remdesivir, and it's a 5-day treatment course done intravenously. This is only done during hospitalization. And if patients have not completed their 5-day course, it does not get continued post-discharge. They simply stop it with their last dose received in hospital. Next slide. And tocilizumab for patients in hospital is given as a single dose, and so this is not used post-hospital discharge. Next slide. Now, anticoagulation is a very common thing, and Ben went through some of the scenarios about what to do with the doses of low molecular weight heparin for patients that are admitted to the general medicine ward with COVID pneumonia. And low molecular weight heparin at therapeutic doses is recommended for hypoxic patients requiring supplemental oxygen, and that would be low flow oxygen, so typically delivered by nasal prongs. And this is given for up to 14 days during that acute illness period. And at the time of discharge from hospital, anticoagulation is typically stopped unless there's another reason to use anticoagulation, such as the patient was diagnosed with DVT or PE during hospital admission. Next slide, please. There is some information in ongoing studies, as well as some completed studies that we'll touch on as to whether or not patients should receive post-discharge anticoagulation prophylaxis. So there's an ongoing trial called Active-4C, which is being led out of the United States. And this is comparing low-dose apixaban 2.5 milligrams twice daily to placebo for 30 days after patients are admitted to hospital for at least 2 days. This is an ongoing study, and at the end of December 2021, they had recruited approximately 1,000 patients. And their target sample size is up to 4,000. So it's a long time off from completing recruitment, but we may have some information depending on how recruitment goes and whether they need to stop the trial early. There was recently a published study called the Michelle trial that was published end of last year in the Lancet, and it's called Michelle trial, and it compared rivaroxaban 10 milligrams daily to no anticoagulation for 35 days in patients who were admitted to hospital with COVID pneumonia. And this is a trial that was conducted in Brazil. There were 16 sites, and 320 patients were included in the study, half in the rivaroxaban arm and half in the no anticoagulation arm. In order to be included in the study, patients had to have an improved risk score of 2 to 3 with an elevated D-dimer, or an improved risk score of 4. And there was a composite outcome that included symptomatic and asymptomatic VTE, fatal VTE. The asymptomatic VTE was detected on screening ultrasound and screening CT scans of the chest to look for pulmonary embolism, as well as arterial events and cardiovascular related mortality. When you look at the results of the trial, the composite outcome was significant for patients who received rivaroxaban in that they had fewer event rates. However, when you look at each component of the composite outcome, nothing was statistically significant. And so for me, this is a really important thing to understand, that asymptomatic VTE may not necessarily require treatment, especially when you have to do things like organize for CT scans of the chest. And that's not practically something that we can do in Canada, where it's not readily available to do that. The other important thing is that there was no bleeding events in either arm. So for patients who did receive anticoagulation, there was no significant bleeding complication. So when I look at patients who may require post-discharge anticoagulation prophylaxis, those are really patients who may have had prior VTE, such as VTE after a knee arthroplasty, for example. And so that might be a patient that I consider higher risk, where I may consider discharging them home on DVT prophylaxis. And in terms of when I initiate that, it would be at the time of hospital discharge and continue it for anywhere from a week to perhaps up to a month or 35 days, such as the Michelle trial did. If somebody had a DVT post-knee arthroplasty at day 20, then I often extend their DVT prophylaxis for future surgeries up to day 30. And so that might be a strategy that I would employ for a patient like this being discharged from hospital with COVID pneumonia. Next slide, please. And so we heard about sotrovimab, and again, that's given either pre-hospitalization to reduce risk of hospitalization for patients that are at high risk. And in some centers, it is used in patients who are admitted to hospital. But again, this would only be done in hospital and not post-discharge. Next slide, please. And I think this is the last slide for us, bringing us to our question and answer period. And I will turn that back over to Jim Douketis for that, please.
Okay, thank you very much, everyone. So we've really gone through the entire spectrum of COVID-19 illness, omitting, of course, the ICU setting, which is very different. And we have a lot of questions to go through in the last 20 minutes or so that we have. And many of them, not surprisingly, are focusing on the outpatient setting. So, Dominic, one of the questions that we received was, is there any role, is there any evidence to support multimodal outpatient treatments similar to what we're kind of been looking at in the inpatient setting?
We don't have the data to, as far as I'm aware. I haven't seen any actual trials or even observational studies that would have compared combination treatments with single treatments. But combination, for example, of fluoxamine and budesonide, we see quite a bit being used, and just theoretically it makes sense because you have sort of two different mechanisms how you approach the disease, but it's still a big unknown, unfortunately, and I think there's certainly more to learn for us, in particular now with Paxlovid as well, in the mix, what combination may and may not make sense, but too early to tell at this point.
And another question, which again, we don't have a lot of data on, is the situation of a pregnant person acquiring a COVID infection. And do we have any information at all on the risk to the mother at the time of delivery and to the risk to the fetus?
So we do know that a pregnant woman is at higher risk compared to a similarly aged non-pregnant woman. And that's why there's been, at least in Ontario, pleads to get pregnant women vaccinated, because we did see more severe outcomes. And there was a time period, I think it was with Alpha last spring, where we actually saw a significant increase in pregnant women requiring hospitalization. So a big yes to vaccinating, even during pregnancy, if not done prior, to prevent that. Still relatively low risk, but certainly higher risk than in the absence of pregnancy. And it looks like that risk continues into the postpartum period, something that we've seen very significantly with H1N1 as well, interestingly enough, because probably that level of immunocompromised status remains for a certain time period until it recovers. The risk to the fetus, there's an increase in stillbirth and preterm birth. Again, low risk, but there is some signal there. Again, just reiterating, you can prevent severe disease with those risks to the fetus with the vaccine, and that's the current recommendation. And with mild disease, I'm not aware of any significant risk to the unborn.
Yeah. So again, the importance of vaccination in all populations. And on that topic of vaccinations, Alan, we had a few questions about the safety and the timing of vaccinations in patients who have a history of venous thromboembolism, so pulmonary embolism or deep vein thrombosis, or who may have had a recent event like that. And then the second part of that is the safety of anticoagulation in any anticoagulated, the safety of vaccination, in any anticoagulated patients. So what do you recommend to your patients when they ask you these questions? I'm sure you get a lot of them.
Sure. Well, I think the first thing is it's clear that there does not seem to be any increased risk of thromboembolic events associated with the use of mRNA vaccines, which is pretty much exclusively what we're using in Canada. So there's no reason to hesitate to use these vaccines in patients with a history of venous thromboembolism. With regard to patients who are currently anticoagulated, really the same thing applies. There's certainly no risk of bleeding complications associated with it, with the exception of perhaps a little bit more bleeding from the puncture site from the vaccination. And when I vaccinate these individuals, I do, advise them to put a little bit more pressure on the wound, or wound if you want to call it that, for a few extra minutes. It's interesting, though, that all patients are asked when they go to vaccine clinics if they are taking anticoagulants, which I think is discouraging some of them and scaring them. I don't really think it's particularly necessary. I don't think that anyone's going to hemorrhage from a tiny needle prick.
Yeah. Well, let's hope you're getting still a lot of calls about vaccinations, especially from those who are getting their first or their second dose.
Jim, may I just interrupt for a moment, please? I picked up an error when I was going through the slides. The dosing that is on the slides, and I want to correct this for all of the participants, for the fluvoxamine was specified as TID, which is a typo. The dosage for fluvoxamine is BID, not TID. So correcting that.
Thank you, Alan, and we appreciate your attention to detail, and we befitting of what we do at Thrombosis Canada. Moving now back to the inpatient setting, Ben, one of the questions we got, actually a couple of questions for you are, first of all, what if a patient is transitioning in terms of their level of care? Let's say they're going from the ward to an ICU setting, and you had treated them with therapeutic level anticoagulation, and now they're going to the ICU. And then the flip side of that is, what if they were receiving a prophylactic agent while they were in the ICU, and now they come back to the ward? How would you manage the anticoagulation in those situations?
So those are great questions. Actually, I'll start by saying there's really no evidence to manage those cases, although they are common. What is done, pragmatically speaking, at least at my institution, and I think at many others as well, is that if an individual is on the medical ward on low flow oxygen, receiving therapeutic anticoagulation for prophylactic indications in the context of COVID-19, and they progress to high flow oxygen, where they could still be on the medical ward but would be considered critically unwell, or actually move to the intensive care unit, the typical practice at that point would be to reduce the dose of the anticoagulant to a intermediate or a prophylactic dose, unless, of course, there's another indication for anticoagulation, for example, proven VTE. And so to be clear, what's done typically is reducing the dose if a patient becomes critically unwell. I'll also highlight that the duration of therapeutic anticoagulation is 14 days at most, followed by a reduction to prophylactic anticoagulation, assuming they don't become critically unwell. On the flip side, if the patient is going from the ICU back to the medical ward, my own practice, and I think this mirrors others as well, would be not to increase the dose of the anticoagulant, mostly because at that point, if the patient is now being liberated from the ventilators, requiring less oxygen, presumably they're no longer in the acute stages of COVID, which is really where this therapy has been shown to be effective. And so my own practice would not be to increase the dose of the anticoagulant in that situation. I hope that's clear.
I think just to emphasize, when we're talking about anticoagulation and what was studied in the trials, most of the agent studies were low molecular weight heparins, I think in about 80% or so of cases. And I think we had a question about, well, what if my patient has severe renal insufficiency? Well, I think you can consider using intravenous unfractionated heparin, because that was also studied as an alternative. But just to that broader issue, Lana, in your role as a hematologist and internist at the Ottawa Hospital, what's your take on that in terms of management, as per what Ben mentioned?
Yes, thanks, Jim, and thanks, Ben. So our practice is very similar to what Ben described being done at his institution. One thing that I would add is the role of high-flow nasal cannula and use of that in patients admitted to hospital wards. So because of high volume of admissions to the intensive care unit, at our center, we were using a lot of high flow nasal cannula on the ward. And that does technically tip into the criteria for critically ill patients according to the trials. And so again, it would be important to be aware or mindful at least that you may want to lower the dose of anticoagulation once patients become dependent on high flow nasal cannula, because that again did meet the definition for critically ill patients where we saw that there was no benefit to using therapeutic doses. So just to keep that in mind as well, that they don't necessarily need to physically move location to modify your dosing strategy.
Yeah, that's a very important distinction between low and high flow oxygen. Thanks for bringing that to the fore. So I'm going to move now from the hospital situation back to the outpatient setting. And Lana, one of the questions that we have actually had to deal with a lot at Thrombosis Canada is relating to drug-drug interactions between direct oral anticoagulants or DOACs and patients who, as we heard from Alan and Dominic, may be eligible to receive Paxlovid. So how would you handle that sort of situation? And I think we have some slides as well to supplement your comment.
Yes, so thank you. It is a common question, and we anticipated this question. And as a group, Thrombosis Canada, we put out this statement last week on our website, and it was emailed to our members as well. And really, the intent of this statement is to highlight the importance of drug-drug interactions between Paxlovid and direct oral anticoagulants. And we want to make people aware of it because currently, at least in Ontario, the Ontario Science Table recommends using sotrovimab before using Paxlovid. And so that would be one of my recommendations, that if there is an alternative available, then to use that for patients who develop COVID infection. So to use sotrovimab so that they can continue using their direct oral anticoagulant. Really, a lot of these drug-drug interactions can be quite harmful, and it is difficult to predict elevated drug levels of anticoagulants and how severe that may be, and how risky the bleeding risk may be is difficult to predict. So in my general recommendation, it would be best to avoid using that combination of drugs if at all possible, and to use sotrovimab if needed. We do have on our Thrombosis Canada guides a drug-drug interaction. Thank you. This is a slide of it here showing a lot of the important drug-drug interactions, and Retonavir and the direct oral anticoagulants is on this. Paxlovid is not, because it just became available. So this guide was updated end of last year. And so it is a useful tool that's available on Thrombosis Canada. And I do think that people need to be aware of drug-drug interactions, not only with our direct oral anticoagulants, but with also common other antithrombotics such as antiplatelets like clopidogrel and ticagrelor. So those are other areas where people need to be aware of those interactions and make decisions accordingly.
Thank you. Excellent. And we hope our audience can refer to these resources. And I'm just going to finish off by asking maybe Dominic a bit of an epidemiologic question from one of our audience members who wants to know, why are we getting a decline in hospitalizations across various jurisdictions? Could it be because of these new treatments like Paxlovid? I'm sure there isn't a one singular reason. Dominic, what's your take on this, what we're observing happily these last couple of weeks?
Yeah, we haven't used that much Paxlovid yet, as far as I know, so that wouldn't be the explanation for that. I'm pretty sure we were able to prevent a sizable number of hospital admissions with sotrovimab prior to that, until we run into more supply issues there. The main reason at this point is just the epidemiology, right? We probably peaked in Ontario, probably second week, maybe first week of January. And what we then see a couple of weeks later, typically starts 1 week later, but certainly 2 weeks later, we see the effect on hospital admissions. And I think we are still probably on the downslide in terms of community transmission, and this will translate into our hospital admissions. And this is well aligned with what we see in terms of healthcare worker being absent because of symptoms, positive exposures, and so on. So all of those things keep coming down, and I think that's the single most important reason at this point. But certainly, I'm optimistic that Paxlovid will help us as an additional tool, and hopefully, eventually the other antivirals as well, to prevent hospital admissions, so we get less of an impact of an increase in community transmission in healthcare.
Well, thank you, Dominic. I'm going to leave you with the last word on this. Of course, it's not going to be the final word. We're going to hear more about this in the coming weeks. And I'd like to bring our session to a close. But before I do that, I'd like you all to try to complete a very brief evaluation. We rely on these very much to develop our programs, so your input is of pivotal importance to us. On a broader level, from the standpoint of Thrombosis Canada, we'd also consider that you think about donating to our organization so that we can continue our knowledge translation initiatives that include programs such as this. So please check us out, and we thank you for your consideration. So with that, I'd like to thank Drs. Alan Bell, Drs. Dominic Mertz, Benjamin Bell, and Lana Castellucci for their contribution. And above all, thank you, the audience, for your participation tonight. We do have a similar program coming up next month, as well as other educational programs. So please check us out again. And once again, thank you, and wish you all a pleasant evening.